Welcome to the Department of Healthcare Access and Information HCAI webinar titled 2022 Title 24 Intervening Code Cycle Part 1 and Part 2 Volume 1. This is a great opportunity to learn about all of the code changes within the California Building Standards Codes and the California Code of Regulations that were published January 1st, 2024 and will become effective July 1st, 2024. During this presentation, we will be discussing what's new with project closeouts, fees for projects with no construction, inspector of record conduct, new behavioral health observation areas, OSHPD 6 chemical dependency recovery hospitals, and much, much more. So if you're ready, please be sure to engage, take notes. We anticipate this being a very informative webinar for you. And if you haven't done so already, feel free to download a PDF copy of this presentation available to you under the Go-To Toolbox under the Handout section of that Toolbox section. Again, that's under the Handout section. There's a PDF copy of this presentation, so you're more than welcome to download and follow along. We're scheduled to be here for about 2 hours, which includes a question and answer session at the end of the presentation. If you have a question during the presentation, please type your question into the questions section of the Go-To Toolbox, and we will answer them the best we can during the presentation. Also, at the end of the presentation, you'll have an opportunity to raise your hand and engage in a conversation with the presenters. All you have to do is click on the hand icon next to the Go-To Toolbox, unmute yourself, and then we will unmute you so we can have that meaningful discussion. Please be sure to keep your questions generic. If you have a specific question about a specific project, feel free to send us an email over to regsunit@hcai.ca.gov. That's regsunit@hcai.ca.gov. If the presentation experiences transmission difficulties, please log out and log back in using the same login information sent by the Go-To software when you registered for the presentation. Today for a presenter, we have Mr. Richard Tannehill, architect and deputy division chief here at HCAI. And in the background, helping answer some of the questions that you'll be asking, we have Mia Marvelli, who is an architect and health facilities review supervisor, Lori Campbell, staff services manager, Simrit Kama, staff services analyst here at HCAI. Once again, thank you for joining us, and we hope you enjoy the presentation. Richard, the presentation is all yours.
Thank you, Caesar. Hello, everyone. We have a lot of information to go through today, but we do encourage you to ask questions as we go, because we're probably going to stop and answer the questions when it's more topic related. So what we're going to be covering today is changes in the intervening code for the administrative code, as well as the building code, part 2, volume 1. So as Caesar mentioned, I'm Richard Tannehill, the Deputy Division Chief for Northern California for OSHPD under HCAI. And also, as Caesar mentioned, Mia Marvelli will be in the background, helping out with some of the Q&A and chiming in as needed if I forget anything. So we are partnering with the AIA California for continuing education credits. If you have signed up individually for this webinar, you should receive a certificate that will be downloaded to you. But if you did not sign up, or if you're in a conference room with other people, only one certificate is issued. These are self-reporting, but the list of attendees will be forwarded to the AIA for confirmation. So we're going to jump right into the 2022 Administrative Code, Part 1. This will be the intervening changes that come into effect on July 1st. The Administrative Code goes into effect 30 days after it's approved by the Secretary of State, and does not lock into a code cycle like the building code does. It goes into effect immediately. We are actually putting into effect on July 1st, along with the other changes, but it does not lock into a previous project. So any changes in the administrative code will take effect for all ongoing projects. because it's not a building standard. It's basically an administrative process and how we do our job. So starting off with the preparation of construction documents, you'll see a lot of changes removing reference to paper plans to the office. We used to have weight restrictions, size restrictions. Those have all been removed. We're about pretty much 100% electronic plan review now, so that's not much of a concern. But so a lot of references to that. We're not going to go through them all today, but just note that all those references have been removed from the administrative code. One of the things that we're adding under 7115B for architects and engineers that are responsible for preparation of construction documents. Actually, I'll stop here for a second, just say there's going to be a lot of reading, unfortunately, just by the nature of what we're doing. So forgive me for that, but I'll try to keep it high level as much as possible and just highlight the areas that are changing. But also there's going to be times where I have to read it to put it into context. So when an architect or engineer that's in responsible charge for the preparation of documents for their license, they have to stamp and sign the drawings. One of the provisions that's been in there that's caused a lot of confusion in the past is item 1 here. It said the structural construction documents or reports shall be prepared by a structural engineer. That is referencing really primary structure for a hospital, for healthcare facilities. Architects may still prepare drawings that maybe have structural components in them that's allowed by their license. So we're just adding that clarification. This has been our policy for a while. When you apply for a project, you have 10 days to upload your drawings, 10 days within that for that application to upload the drawings. And at that point, after 10 days, the project may be closed, voided out and closed out. At the end of a project, this is 7-129 for time limitations, we're adding some limitations to closing out a project, as we have some projects that are taking a year, if not 2 or 3, just to do closeout. So the procedures leading to project closeout shall be carried to conclusion without suspension or unnecessary delay. So once a project gets a substantial compliance or a certificate of occupancy issued, final closeout documentation must be submitted within 90 days, or that certificate may be revoked. Basically, at that closeout signals for CDPH, California Department of Public Health, that they have 100 days to come out and do their survey. So it'll reset that clock, which we don't want to happen. But we also need projects to be closed out within 90 days of closure. And just kind of looking at formatting here, if it's underlined in blue, it is new text. If it's just the regular black and white that you see above here, that's existing text. If it's gray with a strikeout, that's text that is being removed. I should have said that at the beginning. So hopefully that'll make it a little more clear. A little bit of adjustments to our fees. If there is a cost reduction or a zero cost project, the application fee is still $500, but they're also going to be reviewed time and materials just for the cost incurred for the effort to do that review, and it is non-refundable. Okay, we're seeing a lot of no construction projects. These are basically a change of function where we do have to do a review. There's no construction, so there's no cost. So those two will have a minimum filing fee of $250, but also be reviewed for actual costs incurred. Okay. I see a question on there. TNM, time and materials, is billed at our normal billing rate. It's different for different disciplines, but it's basically just to cover the effort to do a plan review for these type of projects, and they're usually pretty quick. So under 7-144 inspections, there are some differences for IORs. Okay. An IOR has to work for the hospital governing board or authority. Okay. An inspector of record associated with a project shall not have any current employment relationships with any entity which is a contracting party for the construction of the project or providing any services for the hospital other than those required of an IOR. So they have to be solely independent of any contractors or construction going on. Also, item B here is inspectors of records are prohibited from any project activities involving the actual performance of construction or the scheduling, coordination, or supervision of construction contractors for the project. Again, keeping the IORs independent of any contractual construction contract requirements. The inspector of record shall be capable of performing all essential inspections functions of the job. So if there is an IOR on the project, inspector of record on the project, we expect them to be inspecting or managing inspecting work. And I'll get to that here. When the hospital governing board of authority proposes more than one IOR for a construction project, a lead IOR shall be identified to coordinate construction, inspection, and communication with the office. That first sentence has not changed. What we have added is that lead IOR must be allocated the majority of their time on project inspection responsibilities. It doesn't mean they're actually inspecting, but it means that they are inspecting, that they're working with other inspectors, that they're scheduling time, that they're on site, they know what's going on that project. So I'm going to read that again. The lead IOR must be allocated the majority of the time on project inspection responsibilities that are identified in the IOR responsibility matrix of the approved TIO program. The lead IOR approved for the project must be present on site to obtain personal knowledge, ensure continuous inspection, to coordinate the inspection responsibilities of additional IORs, and to verify that all required documentation is being maintained on site during the construction of the project, inclusive of the coordination of special inspectors, testing, and project-specific approved testing agencies. That last sentence is a mouthful, but that's what kind of defines inspection responsibilities. We're getting a lot of pushback saying that a lead IOR has to be inspecting. No, they have to be doing inspection responsibilities. In other words, they're on site, they know what's going on. The employment of special inspectors, continuing here, or assistant inspectors shall not be construed as relieving the inspector of record of his or her duties and responsibilities.
Razor, do we have a question here that says, does 7-144 inspection A also apply to architects that are IORs? Can an architect provide design and IOR services to a hospital?
Yes, they can. There are some restrictions around that, but yes, an architect that's certified as an IOR can perform those services.
A little bit of a clarification, the architect or the DPOR in that case should also reach out to the RCO to make sure that the scope of that project is not going to hinder or get in the way of the other responsibilities of them as an IOR as well. So typically that sort of project is something smaller in nature as opposed to a full tenant improvement project, for example.
Correct. Thank you, Caesar. Okay, moving on, 7-153. This is the infamous or famous NMA, or non-material alters section. So 7-153 addresses changes to approved work. First, A covers your ACDs, recommended construction documents, but B does refer to not material that does not alter the work. What we have changed here, one of the things, if those that are familiar with NMAs, is that there's 8 qualifying sections that an NMA has to meet. Item 4 of that qualifying section was new details that are based on other approved details in whole or in part, including reference standards or pre-approved details. That caused a lot of confusion. This is actually being clarified, but also reducing how it's applied. So now it reads that new details that are reference standards or pre-approved details or based on other approved reference standards or pre-approved details. Those would be considered NMAs now. There was a lot of confusion with them being based on other approved details. We are getting just a huge range of details that were saying, well, this is based on detail 5 when they had really very little to do with them. So this is going to clarify that. Some people may like that, may not like this, but it is a lot clearer on how to apply these. Now, it doesn't mean you can't do a detail that's based on another approved detail. Just means that that's not one of the qualifying factors for it. It would still have to meet one of the other qualifying 8 factors. I'm not going to read through all of this, but this is basically a code of conduct for IORs that was added. This is a code of ethics. We're not going to go through all of these. If you have time to read it, it's in the handout, it's in the code. So 7-1, again, continuing with the NMA section, this is actually 7-300 for plan approval. Sorry, that's a wrong title here. For emergency repairs carried out without the office plan review and permit in the aftermath of the emergency, the drawings have to be uploaded within 10 days of the emergency authorization. Okay, if it's truly an emergency, treat it like an emergency. So we have to have drawings uploaded within 10 days of the emergency authorization, and any back check comments will have to be returned within 10 days. Again, we're being asked to expedite these, and we are expediting them. We expect the same on the other side, that these be treated as important as they are and get these drawings turned around. And now this isn't the final fix. This is the what the temporary authorization is allowing you to do. So if a generator breaks, it's not the replacement of the new generator, it's the corrective action to provide either a temporary generator or a temporary fix on the other generator. So hopefully that'll make it clearer. So that's the end of part 1. Any additional questions, Caesar, on that before we go into the building code?
No additional questions, Richard.
All right, thank you. Now at the end, we will be having Q&A. If you have any other questions on this, go ahead and type them up and we will address those at the end of the presentation. So moving on to the building code. Again, this is just part 2, volume 1, and it's the stuff that OSHPD has responsibility for. So one of the things that happened, and most people don't even know it happened, was in the 2022 code, we added an OSHPD 2A and 2B. Those have gone away. We went back to just OSHPD 2. So unless there's specific questions on that, because we really haven't enforced it, I'm just going to move on to the next one. So any reference or description to 2A and 2B has also been removed here. So basically, all skilled nursing facilities are treated as OSHPD 2. We have also added, as Caesar mentioned, that an OSHPD 6, which is your chemical dependency recovery hospital. And this one's just a little tricky in that it's called a chemical dependency recovery hospital. It has been for years and years, but it is not an actual hospital building. But it is, because of a law that was passed, it is could be under our jurisdiction. So the enforcing agency, where it's highlighted here, says basically off statewide health planning and development, is actually being changed to local departments unless it is in an actual hospital building. that would fall under OSHPD jurisdiction. Otherwise, it will be going to local jurisdictions. We do not have enforcement agent enforcing jurisdiction over all chemical dependency recovery hospitals, just the ones that are physically within a hospital building under OSHPD jurisdiction. So that is being clarified in the triennial code.
Hey, Richard, this is Mia. Can I add on to that a little bit?
Absolutely.
Sure, yeah. Um, just to add on a tad bit to this, when I was learning a little bit more about these, and I like to call them a service that can be provided in a hospital, and that's where it might fall into one of our OSHPD 1 or 5, or even 2 for that matter. But anything else, and this is what is kind of tricky, is these are already being built. These buildings with these services are already being built out there, by the enforced by the local jurisdiction. And what was explained to me is when you think of the Betty Ford Clinic, which is a pretty popular example, is that's way outside of OSHPD's jurisdiction, and those are the types of buildings that are built for that type of care, and licensed differently than a 1 or a 2 or a 4 or 5. So I hope that kind of helps clarify that a little bit.
So Richard and Mia, we do have a question regarding this topic. The question reads, what happens if the locals won't review the OSHPD 6 regulations?
These are a little bit different from clinics, and Mia, you can add on if you want, but these are being handled. They're already reviewing these. If the regulations, when we look at the OSHPD 6 regulations later on, they're very residential in nature. They're actually more R occupancies than they are I. Typically, if you see these in a general acute care hospital or a psychiatric facility, they're going to be treated as med-surg patients or psychiatric patients. So that's why there's a very big difference. But we took the psychiatric code and whittle it down to meet these requirements. So they are basically our occupancies. They're typically not locked. A patient risk assessment is required, but most of them are not locked. They're more residential in nature. Local facilities or jurisdictions typically do review these. They have been reviewing them. We have the same problem with clinics where some jurisdictions won't do it. And at that point, we'll have to treat it on a case-by-case basis. Mia, anything else to add on that?
No, thank you.
Okay, we'll move on. We'll be coming back to OSHPD 6 in a little bit. Okay, there's been a clarification and definition of some of the types of equipment we use, primarily interim equipment. It used to say temporary equipment that will be used for the duration of construction, but it's actually kind of redundant because we have temporary equipment. So interim equipment means equipment that will be in use for the duration of the need of the equipment, not to exceed the duration of construction. So in other words, if a piece of equipment is used for construction, it is considered interim, and it's only to be on site for the duration that it's actually needed, that's fulfilling a purpose, then it should be removed, but no longer than the duration of construction at the longest. So hopefully that provides some clarification on that. In addition, and this is kind of going opposite of what I just said, what movable equipment is actually fixed equipment that is designed to be detached or unanchored and replaced. Movable equipment is typically fixed as it would, but it has anchorage that can be undone and the equipment moved for servicing or cleaning around it, things like that. But it is actually considered fixed equipment, that just the anchorage is a little different. Okay, hopefully that'll provide some clarification on that. Moving on to definitions, definition of a patient room has been revised. It used to be only a licensed patient bedroom. We've added the terms for for rooms occupied by one or more individual during an overnight stay for 24 hours in a health facility. What was happening here is you have, for a good example, is LDRPs and LDRs. An LDRP, labor delivery recovery postpartum, is a licensed bed, so it met the definition of a patient room. It is identical to an LDR. The only difference is an LDR is not a licensed bed, but we had different requirements. In theory, 10% of an LDRP, which is a licensed bed, had to be accessible, whereas an LDR, 100% had to be accessible. So we added this definition. So for rooms, this would also be observation units, things like that, that aren't considered licensed beds, but they can still meet that 10% requirement for accessibility and not 100%. Okay, the other language here is just showing where that comes from and how we got to that conclusion. We also added a definition of a treatment room that wasn't in there previously when we added treatment rooms last cycle. So we just added that definition as a room designated for the performance of patient care activities that require high-level disinfection or sterile instruments, but do not require the environmental controls of a procedure room. So these are basically equivalent to a class 1 imaging room.
Richard, we
Yes.
have a question regarding back to OSHPD 6. The question reads, are OSHPD specific definitions also going to be tagged with OSHPD 6 banner as they are currently with OSHPD 1, 2, 3, etc.?
Yes, but there's very few of them. There are not a lot of special requirements for OSHPD 6. It's more along the lines of, and we'll go through the OSHPD 6 section. It's basically a new section we added, 1229, to the building code that defines the minimum requirements for an OSHPD 6. There are not a lot of air, electrical, other architectural, structural requirements for an OSHPD 3 like there are for an OSHPD 6, like there are for an OSHPD 3 and some of the other categories. Okay.
Thank you.
One of the things that State Fire Marshal did, and I'm just going to touch on it briefly here, not going to go into depth, but they removed I-2.1. What we see here is the previous language that for an institutional group, I-2.1 is a healthcare facility that receives persons for outpatient medical care that may render a patient incapable of unassisted self-preservation, and where each tenant space accommodates more than 5 such patients. I highlighted 5 because that's kind of more of the change here. They've removed this, so it will no longer be under occupancies or occupancy groups, and instead it's going to section 422, which has been there for ambulatory care facilities. So the requirement here is you look under the separation, ambulatory care facilities where the potential for 4 or more care recipients are incapable of self-preservation. So went from 5 to 4, that's the biggest change. If you can see here, they're still required to have a 1-hour fire barrier. They still have a lot of the same requirements. So that's why we dropped. It seemed like we had an I-2.1 that really didn't provide anything additional than what model code now provides. And so if there's any questions on that, just let us know. We may do a brief webinar on that in the future, but because we thought it would be confusing, but the more we looked into it, it really doesn't change a whole lot of what's going to be provided. This one I'll go through real quick. All we did, we had medication, medicine, different terms. We just went through and made everything medication dispensing. So there was a consistency on how it was approached. So that's all this slide is showing. This is just a removal of a pointer that no longer exists. 4.3, table 4.3 no longer applies to staff toilets. Because in the plumbing code, we have revised that accordingly.
Richard, if I can interrupt real quick. We do have a couple of questions regarding B occupancy. The overall question is, does the removal of I 2.1 mean that all ambulatory care facilities are now B occupancy uses?
Yeah.
Perfect, thank you.
Yeah, but there are still requirements. If there's four or more than four people incapable of self-preservation, they still have the separation requirements, things like that. Okay. On the med gas outlet table, we did some slight modifications for the addition of class 1, 2, and 3 imaging rooms and for procedure, treatment, and operating rooms. And just number 15, we just added class 3 imaging to it, so it's clear. And on line 39, we replaced interventional imaging to a class 2 imaging room. This is just a modification made to meet the help assist with the removal of the I 2.1. Outpatient clinics or outpatient departments, kind of redundant, so we removed that section since outpatient departments no longer exist. But outpatient departments caring for one or more non-ambulatory outpatients shall have a minimum corridor hallway of width of 6 feet. That is actually not new, it's just being relocated. And then there was a section here that was changed because that used to be previously in the I 2.1 section, so it's now here. So it's still the same requirement for clinics to have the 6-foot corridor unless there's beds and gurneys, and it's still 8 feet. Okay. Also for windows screens, windows and screens, we had operation and sill heights identified. We allowed the sill heights before in intensive care units to be up to 60 inches. But what the Title 22 actually says is special nursing care areas. So we just realigned the language because there are different types of special nursing care areas in addition to intensive care units that you have the higher windows that are allowed. And we put in the exemption that sill heights does not apply to newborn nurseries and rooms intended for occupancies of less than 24 hours. And again, that's from Title 22 alignment. We, at the request of industry, we added sterile core to the same ceiling and carpet requirements as a surgical unit because a sterile core is actually sterile, as its name states, and it must meet the same requirements of the operating rooms that it's servicing. So we just added sterile core on there. This has been getting a lot of attention. This is our addition of class 1, 2, and 3 rooms. It's getting a lot of attention, unfortunately, in a negative way, because it's very hard to siphon out what is basically a class 2 imaging room. But we did add some clarification for class 1. We added before we had services that use natural orifice entry and do not penetrate natural protective membranes. Now we added a B option with an or that are low risk needle-based procedures that do not require a sterile field. What we are finding is that some needle-based procedures do require a sterile field and they are not qualifying as class 1 imaging rooms, and probably rightfully so. So I'll just preface this right now with saying that we are continuing to work with CDPH and FGI to refine the language for class 1 and 2 and 3 imaging, as well as the procedure, treatment, and operating rooms. Previously, our code required that all traffic going into a surgical space went by the control station. We did provide an exception for staff locker rooms. A lot of the times these are provided back of house, and that the staff can enter the locker room, don their protective gear, and enter the surgical service space without going through the control station. Okay. And we also clarified the requirements for CT scanners, that that CT scan spaces shall accommodate the equipment with a minimum of 3 feet on sides and the foot of the equipment, as well as required service clearance at the rear. So the service space requirement is going to be based on the machine that's being used and the specs provided. But we do require 3 feet on the sides and at the foot. So 3, so we're basically for patient access. For the pharmacy space, we added pharmacies, either a cycle or 2 back. We had a lot of minimum square footage requirements, and we are going through and deleting the square footage requirements for that, as the equipment itself is going to define how much room is needed in the compounding rooms and elsewhere, not a required set square foot minimum. So most of the square footage requirement for the pharmacy compounding has been removed. Same thing here. And then under finishes, we just added some clarification to align with the USP requirements. The surfaces for ceiling, wall, floors, fixtures, shelving, and work surfaces, counters, and cabinets shall be smooth. And we previously had that ceilings that were like ACT type ceilings that are removable had to be gasketed. They actually cannot be gasketed because the gaskets provide a lip that you can get in debris under, and it's very hard to clean. So they actually need to be removed. The word gasketed, they have to be clean room style scrubbable panels and able to withstand cleaning chemicals. If ceilings consist of inlaid panels, the panels must be caulked around each panel to seal them to the support frame. Again, that is to prevent entry of any debris. Central sterile supply minimum requirements. It used to say rooms and distinct spaces shall accommodate the following services and equipment, and it listed the equipment. It was adding some confusion, the word and, so we just replaced and with or. You have a room or a distinct space. You don't have to have both. Okay, again, that's the code nerds in us are get right down to the words. One of the things that was misaddressed is morgues and when they can be exempt. It used to be believed that anything over 100 beds would be, or under 100 beds would be exempt from having a morgue, but that's actually not the case. If it's from 50 to 99 beds, they don't have to have a morgue if they can show that they can contract with outside facilities. If it's a bed capacity of 100 or more, they actually have to have a morgue. It was always believed that those can also be provided by outside agencies, but it is actually required if there are 100 or more beds. Okay, and one of the things that we're seeing lately was that a lot of people in the morgues they're requesting scrub sinks. A hand washing station was previously required, so we added the term scrub sink here to just allow that to be done without any alternate methods of compliance. You'll see the morgue come up in psych facilities as well too in a little bit. Intensive care units, somewhere down the road, the requirement for parent gowning was dropped from the requirements of a control station for a NICU. Title 22 does require a gowning area for parents or visitors, and that has been added back in. This is actually the purple language is for Title 22, shows that gowning is required. For obstetrical facilities, primarily LDR and LDRPs, this is for infant resuscitation. There has always been some confusion about what was required for infant resuscitation. Is it required in the room? Is it okay to put it outside of the room? If it is outside of the room, do you need it inside of the room? So working with CDPH, we have clarified that if an infant resuscitation room is not provided elsewhere, it must be provided in each LDR or LDRP room. If there is a separate infant resuscitation room outside in the unit that they can bring the infant to, is there's a need, it does not need to be provided in each room. So hopefully that'll help clarify that. Okay, we've had emergency observation area for emergency departments for quite some time. This is an observation area for patients to be observed before they're either released or admitted. What we have added was the option for behavioral health observation areas. These are basically follow the same principles as a regular observation area, but it's primarily for behavioral health patients. And the square footage requirements is much less, about half. Instead of 80 square feet per patient station, it's only 40. There's only a clearance required on one side of the patient area. What we were seeing coming in were literally called dormitories, where they had like almost theater seating with patients. In behavioral health, you don't want the patients that close together. So we provided some guidance around that to allow these and to be a little bit more or less area suckers, if you will. Now this is what we found, people trying to use these, they want to move the chairs around, and that's fine. They just have to demonstrate that they can meet these minimum requirements for the stations that are in there.
Richard, if you don't mind, if we can go back to the morgue topic, we have a question regarding a scrub sink. The question reads, is a scrub sink provided at a morgue required to be accessible?
No, it's not. The only accessible scrub sinks that we require are for pharmacy, for compounding. Actually, I take that back. We don't even require those. They do provide them, but we don't require them to be accessible. So no, scrub sinks do not need to be accessible.
Thank you.
Continuing with the emergency department, there was some confusion in the staff lounge requirements for toilets and changing areas. Again, what we were seeing was that the staff lounge, they were putting toilets, the lockers in the toilet rooms and shower rooms themselves. So if that toilet or shower was being used, access to the lockers could not be provided. So we just clarified the language. You have your staff lounge shall be provided in the emergency department, then a staff clothing and changing area. Appropriate area shall be provided for male and female staff working within the emergency service space. The area shall contain lockers, showers, toilets, and hand washing stations. So we made sure those were separated out. And then we renumbered the rest of it. Fast-tracked areas before were required only to be in patient rooms. So we just added the same allowance we have everywhere else for them to be in multi-bay type environments and defining what those bays would be, 80 square feet, et cetera. So this language aligns a lot with what's required in other areas that have multi-bay. We just, for some reason, the fast-track area was required to be in individual rooms. So now they can be in bays. We're seeing again with new technologies coming out is the PET scanners and the CT scanner, their SPECT scanners. may or may not have a CT attached to it. So we're getting a lot of requests that a control room not be provided and that the tech would be in the room with the patient. So we added some language to allow this under the condition that this physicist report show that there is no radiation or damage that can be caused to any tech working in the room. So if you want to do this, remove the control room, it must reflect that in the physicist report. Okay, on the bottom here, this language kept popping out and disappearing from the code and added back in and dropped again for some reason. We're just putting it back in again. Hopefully it's going to stay this time, and just basically saying in multi-base scanner rooms that you have to provide a mobile screen between modalities in those rooms for patient safety and staff safety. And adding the same language about the control room. If the control room is not required, is not desired, it must be in the physicist report. For rehab departments, clarification was added that you must have 300 square feet with no dimension less than 12 feet, in addition to any provided therapy stations. Again, everything has a purpose. What we were seeing is 300 square feet, and they put the individual therapy stations within that 300 square feet, and there was no room left to do any type of exercising or treatment in those areas. So the 300 square feet is an exercise space, and then the individual therapy stations would be in excess of that. We're going to jump over to skilled nursing facilities, so I'll pause there. Is there any questions on what we've covered so far?
Richard, we have a question regarding physicist report. The question reads, does the physicist report now need to clarify or clearly state whether there is no hazard to staff servicing dedicated PET or SPECT spaces?
Only if they do not want to provide a control room. If they do not provide the control room, yes, it must specifically state that it's safe for staff to be in the room while the equipment is running.
All right, and we have two more. Is a scrub sink required in an ED cast room if open reductions are not being performed?
I might have to go back. That's not a change to what we're making, but I know I'm not sure what the code actually says on the cast terms, if a scrub sink is required or not. But I believe it can be either or. I'd have to check that to verify.
All right, and then last question we have is, does behavioral health observation require special requirements to avoid self-harm?
Yes, a risk assessment plan is also required. The patient risk assessment is required. And what we're seeing, a lot of these people, what's being done is they're putting in, say, 15 chairs, because the chair is all that's required in these, and they're using the 40 square feet, but they're making the rooms very flexible so that they can be modified for like more of a milieu type room and different configurations and stuff. That's what we're seeing coming in with these, and that's fine. But they do have to have a patient risk assessment to show that these patients going in there are minimum risk. Otherwise, they're going to be in a full exam room type environment with that they're guarded on.
Thank you. I think we can move on.
Okay. Skilled nursing facilities. Previous requirement for a minimum of 1 bathtub per floor has been removed. As of right now, there are no bathtubs required in a skilled nursing facility. They're 100% optional. We added the same requirements for the patient rooms windowsills if we have seen in other type of patient rooms, so that people can be evacuated if necessary. or can evacuate themselves. That's all there was for skilled nursing facilities. So I'll continue to psych facilities. We just added some clarification in their introduction. They're the application of acute psychiatric hospitals to better align with what's required for 1224 versus 1228. So we've basically added that an acute psychiatric hospital or unit shall meet the requirements of 1224-14 for the unit that provides acute medical care, or 1228-14 for a non-medical unit. So 1228 is basically your non-medical unit, your ambulatory type psychiatric facility or unit, and 1224 would be your medical unit. And also, again, this also requires the patient risk assessment based on the functional program. A specific application shall respond to patient injury, suicide prevention components, patient risk assessment, et cetera. So that's all included there. We just wanted to really signify when would you go to 1224 versus 1228, because you can have a 1228 in a acute hospital, as a distinct part, but we just want to make sure that was clear. I added the definition for tamper resistant. Believe it or not, we get this question a lot. What's tamper resistant? That means it's designed to prevent damage, destruction, or interference, or indicates the product is designed to withstand dismantling, removal of the product, or interference with the operation of the product. Also, within psychiatric facilities, we added an allowance to have translucent film up to 60 inches, and this is for privacy. We almost have an AMC or an alternate method of compliance on every psych facility we do to allow this, so we just put it in the code. And we also added some clarification that the 80% of the floor area of each indoor activity space and dining space shall be provided for observation from the nurse station. This is when you have a observation or activity space, an indoor activity space. You want the nursing staff to be able to see what's going on in that room, so that if anything happens, that they're aware of it. So there was some confusion if that was outdoor windows or if it was for observation purposes. For psychiatric facilities, physical therapy, occupational therapy, and speech pathology are optional. So we just added the language back in where provided for each of those to make it clear that's optional.
Hey, Richard, question going back a slide or two. The question is that 8% or 80%?
8%. 8% of the floor area. Patient rooms are 10%. So they're saying 8% of the indoor activity space and dining space shall be provided with windows. Okay.
Okay, thank you.
I'm working with several of the psychiatric health service facilitators. We have clarified the space requirements for psychiatric patient rooms. Previously, we had 100 square feet for a psychiatric room, a patient room. Title 22 requires a minimum of 110 square feet for all hospital rooms, patient rooms. So 110 square feet was added last cycle. But what we did, that was making, if you look at the definition for clear floor area, it's exclusive of beds. So it made these psychiatric rooms larger than a med surg room, even though they don't have the same equipment requirements. So in this case, we added inclusive of beds of 110 square feet. So you don't have to count the bed, subtract the bed footprint from that square footage. And again, with the considering that you don't have the equipment needs in a psychiatric room under 1228 that you do under a med-surg unit, it allows for the 110 square feet to be total clear floor area. And we just added a pointer to treatment rooms here. As I said, you'd see morgue coming up. There is a requirement for a morgue from 50 to 199 with psych facilities. They can contract out the morgue services. Once it gets 200 or more beds, it is required to have the facility is required to have a morgue in the facility. So the difference is 100 for a regular general acute care hospital and 200 for a psychiatric facility. So coming to the end here, chemical dependency recovery hospitals. First, we're identifying the scope of this. They can be in general acute care hospitals or acute psychiatric hospitals. They also can be distinct part of a facility. A functional program is required with a patient risk assessment, to a safety risk assessment to show what type of patients are going in these spaces. Like I said, most of these are going to be voluntary. They're not locked and they don't have any special requirements. Added some definitions. Again, a hospital, like I said, a chemical dependency recovery hospital in itself is not legally a hospital. So we just added some definitions for this section only, where the term hospital is used is referring to a chemical dependency recovery hospital for this section only. The general construction is pointed back to 1224, so it will have the same similar requirements for construction as a general acute care hospital or 1228 for if it's built in a psychiatric facility. Again, some of this language may change in a future code cycle to make them more aligned with the locals doing their own review and OSHPD doing the review of just the ones that are in OSHPD jurisdiction. Just requirements for examination and treatment rooms, outpatient waiting rooms, the corridor widths be 5 feet. Again, as I go through these, you'll see that the requirements are very minimal. Door window, yes.
Would you mind going back to the morgue conversation? We have a question about the morgue and space. The question reads, can I ask about morgue requirement for acute care hospitals? Can it be located in a non-OSHPD 1 space?
It depends if it meets the requirements. From 50 to 99, it can be contracted out. If it's 100 beds or more, it has to be in the hospital space, in the hospital building, in the OSHPD 1 building. Same thing with a morgue in the psych, which is on the screen now. It must be within the OSHPD 5 building if it's over 200 beds. So if the morgue is required, it is required to be in the hospital building. Hopefully that'll make it clear.
Thank you.
Okay, so we're almost done here. Patient counseling areas are provided, group therapy spaces, physical conditioning, family therapy. These are standard services provided in chemical dependency recovery hospitals. Activity areas, again, very minimal requirements for the activity areas. They have indoor activities. Outdoor activity area is just provided an outdoor activity area. It should be sized to meet the appropriate needs of the occupants and maintain egress. No special requirements for fence heights or locking or any of that. Talks about the residential areas, that they're distinct part units. And general acute care hospital or a distinct part of an acute psych. Like I said, that those would fall under OSHPA jurisdiction. Otherwise, if there's, I keep saying there's really no differences beyond a normal patient room toilet type condition. They shall have hand washing stations. Showers shall be provided, a ratio of 1 to 20 patients. Patient storage area shall be provided. And then you just have your service areas for administrative and office staff. Consultation rooms, conference rooms, group therapy rooms. Minimum requirements for a pharmacy. And dietetic service space shall be provided similar to the requirements of a psychiatric facility. And the shared services for CDR units provided as a distinct part of a general acute hospital may share a dietetic service space. Same with a psychiatric hospital. Again, I'm going through these pretty quick as they're pretty standard requirements. An adolescent area shall be provided. Unfortunately, that is required. And they shall be separate from adult service areas. I shouldn't say they shall be provided, they have the option to provide them, but if they are, they have to be separated from adult space. And requirements for the toilet room, each patient shall, again, this falls under the adolescent part of it. Toilet room should be located more than 100 feet from the bedroom. Again, in adolescent areas, the toilets can be off the corridor. And again, this is continuing. The adolescent areas have activity space, and the outdoor area shall be separate from the adult areas. And education will be required if the expectation that the patients will be there, the school-age children be there over the period of 1 month. And that's pretty much it. So we'll go ahead and open it up again. As I mentioned, if you have a direct connection log on to this, you should be able to download a certificate or it will be sent to you. I'm not sure how that works, but if you have more than one person watching this on the same connection, you will only get the one certificate. And this will be, again, this is all self-reporting to AIA. We're just giving them a list of who attended. With that, we'll open it up to questions.
Great, and just as a general reminder, if you have a question and you want to go ahead and raise your hand to unmute yourself, now is the time. I know that I did see a couple of hands up during the presentation, but this is the time to raise your hand so I can unmute you. You can unmute yourself and we can have that conversation with the presenter. Going back to the list of questions, Richard, why they do that. We do have a follow-up question regarding holding rooms, a body holding room specifically. The question reads, when can a body holding room be used in place of a morgue?
When the morgue itself is not required. Once you get over 100 beds, 100 or more beds in a general acute care hospital or 200 or more in a psychiatric facility, the morgue is required. Then you can use a body holding room. It's not required, but strongly encouraged to have an area to hold the bodies until they can be picked up.
Great, thank you. We do have a hand raised. I'm going to go ahead and unmute you, Mr. Bruce Bigger. I see you have your hand up. I'm going to go ahead and unmute you, so please feel free to unmute yourself, Bruce.
Richard, back on the administrative code, one of the first slides you were talking about 10 days, and one of the other slides was 10 business days. Isn't it 10 business days in both cases?
Yes, Bruce. We'll need to clarify that if it's stated separately, differently.
Great, thank you, Bruce. Moving on to the next hand I see. Let me scroll down a little bit. You've had your hand up for quite some time, so bear with me. Dwight Clements, you have your hand up. I'm going to go ahead and unmute you, so please feel free to unmute yourself. Dwight? All right, moving on. I'm going to go ahead and mute you again. Oh,
Yes,
here
sir.
you go. We hear you, Dwight. Go ahead.
Okay, yeah, mental health. Ligature has been a requirement. Is it still part of the 2022 cycle? Ligature and mental health patient room facilities?
Yes, that's not changing for a psychiatric facility. You
Yes.
do not have the same requirements for anti-ligature in a chemical dependency recovery hospital.
Thank you.
Thank you, Dwight, for raising your hand. We do have another hand raised. David, Kelly, you have your hand raised. David, I'm going to go ahead and unmute you, so feel free to unmute yourself, David.
I'm unmuted.
Okay, we can
Can you
hear
hear
you.
me?
Go ahead.
Okay. Is there a second half of today's presentation? Because it shows 2 hours from 1 to 3.
There is not. We went through it fairly quickly. We will be doing a separate one on mechanical and electrical and plumbing.
Okay. And then I'm doing research trying to find the 96-hour requirement for power. I can find it for the SCIF, but I can't find it for the Class 1 hospitals. Where would I look for that?
For what? 96 hours for power?
There's a requirement to maintain 96 hours of power in the event of an emergency.
Right. What you'll see in the building codes is 72 hours with 30% capacity brings you to 96. So that's where you're going to find it for hospitals.
In the building code, CBC?
Yes.
Okay, I'll go look there.
It might be one of the mechanical code might have that requirement for generators.
Okay, I'll go start looking there.
If you send an email to regsunit at hci.ca.gov, we can get you the exact reference.
Oh, thank you.
And specific to that, we have a clarifying comment from William. William states NFPA 101 is 96 hours for fuel only. So thank you for that, William. Richard, we do have another question regarding scrub sinks. The question reads, can scrubs, let's see. Oh, I apologize. I think we've already answered that. So moving on to the next one, it says, the code says room required for equipment does not state a room. Can SPECT equipment be placed in the room with a scanner gantry, not a separate room?
I'm sorry, I'm not following. I'm going to read along with you.
Yeah, I'll
Go
read it
ahead.
one more time. If not, if we can, we'll go ahead and reply to this answer or to this question privately in an email after the webinar. But I'll read the question one more time. It says 1224.34, the code says room required equipment does not state a room. Can SPECT CT equipment be placed in the room with a scanner gantry, not as a separate room?
Yeah, what this is saying is it's kind of abbreviated in the question. This is referring to a control room or an equipment room for the imaging equipment. A lot of the newer equipment, the imaging equipment comes out with equipment the size of a computer desktop. So the control room is optional depending on the equipment being used. If the equipment's very large, they do want a separate room to store it. I've also seen it done with sliding panels at the back of the room. It just needs a room to store these equipment. Now, again, if the equipment is very, very small, some of these systems, like I said, are the size of a CPU, a workstation. They can go under the control desk, and then the equipment room would not be required.
Perfect, thank you. Thank you for that, Richard. Next question on here that I see, the question reads, are there any changes that would affect structural design?
That will be a different webinar because there are changes to the structural code, but we're not covering that. And I wouldn't even know where to begin.
All right, thank you for that. This is an overall question, not specific to what we have here, but the question is applicable, so I'll go ahead and read it anyway. The question reads, does a project currently under review need to comply with the intervening code changes?
No. Goes by the date it was submitted. So if you submitted your project already prior to July 1st, you're locked into the code under which you submitted it. So the intervening changes do not apply to projects currently under review.
Perfect. And we have a follow-up question regarding the structural webinar. When is the structural webinar?
No idea. Sorry.
I think that's an honest answer.
I don't think it's been scheduled yet. Like I said, there will be other webinars on the code changes for mechanical, electrical, and plumbing, probably one for fire as well, and for structural. I do not know the dates of those.
We'll take advantage of this opportunity. I will mention to everybody on here that be sure to log in and register for updates on our HCAI website by clicking on the subscribe button on the top of the web page on the upper right hand corner to receive updates and webinar announcements as well. So moving on to the next question. It reads, are special inspection firms required to be OPAA, or is this a recommendation?
I'll let you answer that, Caesar.
Great. Thanks. Mia, anything else to add?
Yeah, actually, I did see a question about supplement availability, how to get the supplements. I can speak to that. First, if you purchase the code, you want to contact the publisher because they should be sending you the supplements. The other way is you can go to the building, if you Google California Building Standards Commission and you go to their codes page, most of the supplements are available to download in a PDF, with the exception of the electrical code, so you can contact NFPA for that. And I think the general question was, when do they go in effect? They go in effect July 1. Of this year. So that's all I have.
All right, I'm going through these.
Do you know the answer to the one you just asked about the special inspections? OPAA?
Inspection firms being, so I was going to reply in the text. Yeah, go ahead and feel free to log into the HCAI website under the OPAA requirements. That's where you're going to find a lot of the information, but generally the special inspection firms are required to be OPAA. If not, when identified on the TIO specifically for projects, we are requiring to have that TIO identified, whether you're going to use an OPAA or a specialist or another firm. So the general answer to that would be yes, but there are other ways to go about it.
Somebody know.
All right, let's see. Question for you, Richard. For LDR rooms currently permitted and in construction, does a change allowing for only 10% of rooms to be accessible apply?
I would talk to your region that's reviewing it. If it's under construction, you're probably way beyond that. But I would talk to your plan review team to see if that can be used in AMC, an alternate method of compliance for that. Me personally, I would allow that to be revised if it was necessary to do so.
All right. Next question we have on here is.
I was trouble for saying that though. But yeah, I would talk to them. And
Okay,
you can use.
perfect. All right. Moving on to the next question. Reads 1224.34.1.2.3 imaging equipment room shall be provided. Can this be interpreted as a space for imaging equipment?
I don't have, I'll be honest, I don't have the code open with me right now. I'm actually remote, so I don't have access to everything. But the imaging equipment room shall be provided means it must be provided. Again, if you can, I don't know what section that's specific to, because typically in the areas that it's optional, it says, if required, it shall be provided. So if it says imaging equipment room shall be provided, there might be an absolute need for that, but it varies by the piece of equipment. So again, I don't have reference to see what that exact section is with me. But going from memory, I would say even if it says that, if you don't have equipment to put in that equipment room, I would do an alternate method of compliance to request that it not be provided. Equipment room was being provided for the equipment for imaging stuff, imaging modalities, so that it can be protected and serviced and kept in a different environment. If that doesn't exist, there's no requirement for a control room. An imaging equipment room is sorry, I keep saying control room, I apologize. The imaging equipment room is the equipment for the imaging equipment. And that's one of the things we did recently, went back in the code. It used to be called a computer room, an equipment room, there's all kinds of different things. And we standardized the language on that as well.
All right, we do have a hand up. Joseph, I see you have your hand up. I'm gonna go ahead and unmute you so you can unmute yourself. Joseph, if you're still there, feel free to click that unmute mic. Joseph? Okay, Joseph, I do see that your microphone was green, so I'll go ahead and ask you to unmute yourself one more time, Joseph. All right. Seeing that we might be having some technical difficulties on that end, I'll go ahead and keep moving down the list of questions here. We do have one more question on here that's typed in. The question reads, do you know if there were any changes that apply to outpatient behavioral health clinics? Would it still fall under OSHPD 3?
I'm not sure I understand the question. There are no changes to the outpatient behavioral health clinic requirements. Again, the OSHPD 3 is depending on how it's licensed. So you may have an outpatient behavioral health clinic that does not fall under OSHPD 3 by the owner's choice. Or if there's some that do, it also gets down to reimbursements and things like that, licensing. So I'd have to have more information to answer that correctly. But we did not make any changes, I believe. Actually, I don't even think there's a section specifically for outpatient behavioral health clinic.
Great. And his question, he did ask if there were any changes. So that's quite all right. So I'm not seeing any.
Sorry. Yeah, no, as far as there are no changes to outpatient behavioral health clinics. And if it was an OSHPD or not, that depends on the facility itself.
Great, thank you, Richard. So for those of you who did not have a chance to type a question or raise your hand, we do have that email address that you can always send us an email to ask a question about a specific question or about a specific project or just a general question. That's regsunit@hci.ca.gov. I'll go ahead and do a scan of the questions one more time and then a scan of the hands raised one more time again. And we can go ahead and move on and end the presentation if we have no more. Looks like we just had one more question come in. Says, licensing has been very involved in spatial recommendations based on procedural input from doctors, but not pointing to building code. Will there be future updates to align what licensing is requiring due to procedures?
All I can say is we're constantly working with CDPH and their medical consultants, as well as with the California Primary Care Association to refine the standards for clinics and it'll be an ongoing process. So as new technologies, new treatments come out, we work with them to provide an allowance in the code. Again, just because it's not in the code doesn't mean you can't do it. It's just there's no requirements for it. So I would always be looking at future updates, or if you know of something, again, if you send it to regsunit@hci.ca.gov, we can look into it or work with you on it. Always can give us a phone call to talk to us about it. Again, we do not review typically OSHPD 3, it goes through locals. So we feel it's very important that if there is things that you're seeing at the local level, that we hear about it so that we can either work with that agency or we can provide some clarifying language in the building code for clinics.
All right, thanks, Richard. And then we have last question, and this question comes from the individual who had microphone technical difficulties. The question reads, 1224.35, PT rehab must be 300 square feet in addition to question mark.
In addition to the individual therapy stations. So if you have tables that they're doing therapy on, those are not located in the 300 square feet. So if you have a 10 by 30 square foot area, that's an exercise area where they can have rowing machines, bicycles, that type of stuff. If they're going to provide individual therapy stations, it's above and beyond the 300 square feet. Hopefully that answers your question.
Yes, yeah, the person typed in thank you. So I'm going to do one last scan of the questions and hands raised. So bear with me while I do that. And Richard, any last comments before we close the presentation, being that there's no more questions from the audience?
They're always throwing at the last minute, right? What I want to say is if you're hearing things in the field or seeing new technologies, please reach out to Mia or myself. We do want to make sure that we're addressing new technologies, hopefully before they become an issue, or we can find a way to allow them. We don't want to put any restrictions on innovation out there. So please contact us if you're doing something that you don't see in the code that you think would be a benefit to have there. Again, we're constantly working with the different agencies throughout the state and throughout the United States to improve on this. So if you're seeing anything you'd like to see or any recommendations, please reach out at the email provided, regsunit@hci.ca.gov. And thank you all for your time.
Right, and Mia, any last comments to add?
Yes, just thank you for attending. We're pleased to be able to offer these webinars. Obviously, we want to thank, it takes a while to get these set up. I want to thank our admin team for getting the background of this set up. And Caesar, thank you for moderating. Appreciate it.
Definitely. Okay. Thank you, Mia. Thank you, Richard. This brings us to the end of our presentation. We hope that you found this webinar to be very helpful. Please remember, if you didn't download the PDF handout, you can download it now under the handout section of the GoTo toolbox. If you have a question about this presentation or a question about a specific project, specific issue, as Richard mentioned, send an email over to regsunit@hci.ca.gov. Again, that's regsunit@hci.ca.gov. Be sure to head over to our HCAI website and subscribe by clicking on the subscribe button on the upper right-hand corner to receive inspection service unit, tips of the day, field brief advice, building safety information, finance information, facility data, and much, much more. Again, it's been a pleasure being here with you all today. We hope that you found this to be informative. We want to thank you for doing your part in providing access to safe, quality healthcare environments throughout the state of California. And with that being said, until next time, we shall see you later.